a very exciting time for the lupus community with this new drugs that has been approved. One has not been approved in a while. So without further ado, I'm going to begin. I'd like to take a moment to introduce myself. My name is Sandra Williams-Reed. I'm one of the directors with Lupus Ontario, as well as the chair for the Support and Education Committee. We are really excited tonight because we have we consider him our very own. He's done so much with Lupus Ontario that is joining us tonight. So just before we begin, I just would like to remind everyone on this that we are being recorded. Our webinars are recorded, so those who are not able to attend can view it, or you yourself can view it at a later time. So just for privacy, this webinar is being recorded. And as well as, I would just like to mention a few upcoming events before we begin. Of course, for all our support group meetings, please visit lupusontario.org/support, where you'll find the list of all the meetings where you can register for those meetings, as well as for all our upcoming events. You can visit that site as well. For all our past recordings and webinars, you can visit lupusontario.org/education. So tonight we have with us Dr. Tselios, who will be doing this presentation for us tonight. So like I said, many of you do know him. He's now the assistant professor with the Division of Rheumatology, Department of Medicine at McMaster University in Hamilton. Tonight, Dr. Tselios will present the current knowledge and 2 new drugs that were successfully tested in phase 2 clinical trials in lupus. As you know, it's been many years since something has been approved for lupus. So this is a very exciting time for us. And so without further ado, we would like to welcome Dr. Tselios. Dr. Tselios?
Sandra, thank you so much. The pleasure is all mine. Gail and John, I'm saying it. And Melissa and Ismail and all this, like friends I made with my years in Toronto. So I know we're still talking about the pandemic, and we're still talking about the challenges the lupus community is facing with COVID-19, but I thought to discuss something more hopeful this time. As Sandra said, it's been 10 years that we had an approval for a drug for lupus. And this time around, we are very happy to have like more drugs. And I'm sure that in a few months, we'll be able to share this with our patients, and we'll be able to apply this to clinical practice. So I will present a few things. Some of the terms are like technical, right? Don't be afraid to ask. I will try to explain this to you with the hope to make you understand how a drug is approved, and then I will devote a few minutes in the end to discuss how we can help, how we can assist that process, because we're talking about very expensive drugs that are not, unfortunately, available for everybody. We are trying our best to expand the base of patients for whom this will be available. Now, so we'll say a few things about Anifrolumab, actually more things for Anifrolumab, and then a few things for Voclosporin. The Anifrolumab, why we'll say a few things more, because it was approved recently by Health Canada in December. What we are trying now is to try and make it available through public access to special groups of lupus patients. And I'll talk for this in the next few minutes. The Anifrolumab was approved for non-renal. That means not active lupus nephritis, not neuropsychiatric, not central nervous system disease. So we're talking about disease that affects the skin, disease that affects the joints and other systems. And then we'll say a few things about the Voclosporin. The Voclosporin was approved from the FDA, from the Food and Drug Administration in the States for using lupus nephritis for renal involvement, kidney involvement in patients with lupus. So just a few, I don't want you to go through this in detail. This is not for patients. This is like for doctors, and not all doctors, actually, only those who are really interested in lupus. What is the trouble with lupus and why we don't have so many drugs like rheumatoid arthritis or the other diseases? The pathogenesis, the mechanisms that allow lupus to come to surface, and at some point you will start feeling symptoms and will come to me or any other interested physician, is around here at the very far right of this slide. But the inflammation in lupus and the other systemic connective tissue diseases, will start many, many years before the diagnosis is made, right? So at some point, we believe now that you have some genetic predisposition, some genes found in the family, something is happening with environmental factors like a virus, like a drug, like the ultraviolet radiation. And this interaction will lead to some dysregulation of the immune system. The immune system is theoretically the one to prevent infections, to protect us from invaders, from viruses like COVID-19, from other bacteria. In this case, something is happening. We don't know what exactly, and it leads to the generation of autoantibodies. And then with all these autoantibodies, we'll have like more activation of the immune system, and so on and so on. And at some point, we'll start seeing tissue damage. So a swelling of the joint, a skin rash, some problems with the kidneys, some tests from the kidneys going up in the blood, some tests in the urine to go up. And at that point, you'll come to me and I will make the diagnosis and will start treating you with whatever I have available, right? But we think now, we believe that this is a late phase of disease course already. Anyway, more and more factors of the immune system, immune cells, proteins, other mediators soluble, like hundreds of proteins in the blood have been implicated in how the disease is generated, right? But for the last few years, it seems that there are some proteins that are more relevant to most of these cells that go crazy in the context of lupus. And we call these proteins type 1 interferons here. This little thing that can affect practically all, most of the kidneys of the cells of the immune system, right? And of course, this has been shown to have an implication in arthritis, in skin disease, in renal disease, in central nervous system disease, and virtually most of the manifestations of systemic lupus erythematosus. So what is Anifrolumab? Anifrolumab is targeting exactly this little part of the immune system, this type 1 interferon. To give you an idea of the intensity of research, interference was firstly described in animal models of lupus in the early 80s or late 70s. Right? We knew at that time that something is happening with these proteins and they cause some trouble with the immune system. And it took us like 40 years to get actually an actual drug for use in patients. Right, they had multiple studies, all this news, TULIP-1, TULIP-2, and then there is the long-term extension of the TULIP studies, where they follow the patients who were enrolled in the TULIP 1 and TULIP 2 trials, and they're trying to see what is happening in the long term and if there is any more benefit in the long term. So I will present not study by study, but the totality of evidence, what happened in all patients, right? Just for the sake of time. The patients who were enrolled in these clinical studies, in the clinical trials, had a median age of 42.6. Median means 50% of the patients were above 42.6, 50% were below 42.6 years. With the gray color, this is the placebo. When we're talking about placebo in lupus trials, we mean patients who were treated with the standard of care. By standard of care, usually we mean antimalarials, Plaquenil. Most of you know this thing. Steroids in different doses, various doses, prednisone, right? And then immunosuppressive, some of them took methotrexate, some of them azathioprine, some of them mycophenolate. Some of you know what I'm talking about. Anyway, this is considered the standard of care. And then on top of this, we're trying to add the new medications to see if they will make any difference. So the age was around 40, 41 years, 93% female. Okay, this is the racial distribution. Most of them white Caucasians, black 13%, Asian 11%. Then they had like significantly active disease. That Slidai 2K thing measures the disease activity, and this numbers 11 means that the disease was active. They were taking more than 10 milligrams of prednisone per day in 53% of cases and 51% for placebo. And this is, sorry, let me go back. This represents the interferon signature. What we mean by this, that little protein I showed you, that interferon thing, is regulated by more than 20 genes in our body, and most of them are activated in lupus patients, right? Do all patients have activated genes that promote the production of interferon? No. In the Anifrolumab studies, there were about 83%, as you can see, in well balanced between the active and the placebo group. In general, we believe that it's 60 to 80% of our patients have genes that are activated and promote the production of interferon. So let's go straight to the endpoints, and we can see that more patients who were treated with the Anifrolumab, with this new drug, achieved that Buckler response. What is a Buckler response? Buckler response is a composite, is 4 different things, right? We ask from our patients, 1, to do better with regards to the initial manifestation. So you have arthritis, and the arthritis should go away, right? At what time? Maybe in 4 weeks after the initiation of treatment, maybe in 8, 12, 16, and all this until 52 weeks. Usually the trials in lupus last for 52 weeks, 1 year. So one is this, for this manifestation to go away. The other is that you will not develop any other manifestation. For example, joints get better, but you come up with the rash. This is not allowed. If this happens, this patient is considered like a treatment failure and is not calculated in this number. Then we have the physician's global assessment. So I believe that your disease is active or non-active or moderately active. We have a numerical scale from 0 to 3, in some other studies from 0 to 10. Anyway, this is like the doctor's perception of how the disease is going. And we bundle all this together and we say that, look, if you satisfy all this, you are a success for the treatment. So you go to the success category and not to the failure category. And there was always like a significant difference throughout, from very early during the trial course, even from 8 weeks up to 52 weeks. Patients with Anifrolumab, the new drug, did better when it comes to this outcome. And patients with Anifrolumab had like a 73% higher chance to get to that kind of response, and actually to sustain that kind of response. So not only they went into remission, but they were able to sustain this remission for the duration of the clinical trial. We have other measures as well. That SRI-4 response, for example, over time. What's happening with this? And that was more evident, more apparent in the TULIP-2 trials. By SRI-4, we have a measure of this activity. We call it Slidai. It was developed in Toronto back in 87, 88, if I'm not mistaken. And this was one of these papers was what I was studying through my PhD. And I was intrigued to come to Dr. Hughes and Dr. Gladman and work with them. Now, the SRI-4, for example, is a 4-point reduction in the disease activity score. What this means, if you have arthritis, if you have joint issues, you get a score of 4. For this to be considered a responder, you should have no arthritis at the end of the trial or at any time point during the trial. So if arthritis goes away, you get a reduction of 4 and you consider to be an SRI-4 responder. When it comes to skin, it's not only skin, because skin is marked with 2 in the Slidai. You should have like alopecia, so hair loss, and hair loss goes away. So you have like 2 from the skin, from the rash, and another 2 from alopecia. You get your 4, you are an SRI-4 responder. This is not partial. This is complete. So you have like 10 affected joints and all the joints go away, and we say that you're an SRI-4 responder. In rheumatoid arthritis, to give you an idea, they ask for a 20% improvement. So if you have 10 joints and you have like after the end of the trial or at some point during the trial, you have like 8 joints affected and the 2 got better, you are considered to be a responder. In lupus, on the contrary, it's like all or nothing. We ask for a complete resolution of the trouble you have. What happened with the steroid reduction, the prednisone reduction? More patients in the Anifrolumab group, about 20% more, had the significant steroid reduction to doses less than 7.5. Why we ask for this 7.5? In general, it has been shown that 7.5 and lower is an acceptable dose because it will not give you any significant trouble in the long term, even if you take prednisone for years for 7.5. This is what we were thinking and what we believed until like a few years ago, when we showed that 5 is actually the magic number. I'm talking about patients who cannot discontinue the prednisone. If you can discontinue this, even better, right? Because prednisone is not only acting in the short term, it's acting in the long term. So anyway, 7.5 is for the rest of the planet. 5 is for me. But anyway, the reduction of prednisone to less than 7.5 will decrease the risk of developing organ damage, like cataracts in the eyes, like osteoporosis and fractures, like cardiovascular issues, even other kind of damage. What we have shown from the Toronto Lupus Clinic is that damage over time in lupus is about 50% attributed to steroids. So you have your trouble, you have your disease, and you get your damage from disease by 50%, and then I'll give you another 50% because of the steroids I'm feeding you all this time. And we're talking about years of disease, right? Not only for a few weeks. This is not like an allergic reaction for which I'll give you a few days or a few weeks of steroids and that's it. Or asthma that you will take steroids for a few days and then after the next attack and the next attack and so on. This is like lifelong treatment with steroids. And we now know that less steroids, less damage overall, less trouble. A few things about GLASI. This is an index we measure for skin disease only, not for joints, not for anything else, but the extent of skin disease. This patient did better, but it took time for this to reach a statistical significance. This is another issue when it comes to trials, and I don't know. I'm still thinking how we can tackle this. If you talk to the methodologists, people who run the studies and run the statistics and everything, they will tell you that this difference, like the 5 or 10% difference between the one arm and the other, may as well come from pure chance, right? And this is not going to be reflected to other patients. What is bothering me is, what about people, and I'm sure there are people in the clinical trials, because I have seen them in practice, who respond very, very well to a given drug. For example, if Dr. Tselios has lupus and Anifrolumab is a wonderful choice for his skin disease, and we have seen that he responds greatly, why this patient should not be allowed to have access to this drug? Only because 300 people or 360 people in these two trials did not do as well. Anyway, what happened when we examined the joints? There was a statistically significant, again, response, so more people with joint disease responding to Anifrolumab, but this took time. It wasn't so easy to control the joint disease. It was after 8 or 9 months, as you can see here with the with that green shade. A very important thing in my mind, and I'll tell you why. Number of flares for week 52, so for the 52 weeks for the 1 year of the trial, significantly less in patients treated with Anifrolumab. This will be translated in less steroid use, less cumulative steroids, and less damage from disease activity. Lupus is a relapsing and remitting disease in 90% of the cases, right? It will go up, it will go down, it will go up again, it will go down again. And you will have, as a patient, the trouble of visiting your physician, of increasing the prednisone, of getting more damage because of the prednisone, of getting more stress because this flare will not get into remission now, and all these things. Even for the first year of disease, we saw significant reduction in the number of flares. And they have the impression that as the disease goes on in the long-term extension study, we will see like a greater impact of this, like less flares. A few words about the adverse events, right? When we have a clinical trial, the first thing actually is to check the safety of the drug. If the drug is safe, we can then discuss about the efficacy, how effective this is, right? If it's not safe, we will not have any further discussions. Like many trials were discontinued, not only in lupus, but in other diseases as well, because the safety profile was not acceptable. Like there were deaths during clinical trials, there were like irreversible damage during clinical trials, right? This is not an easy thing to do, right? So what happened in the Anifrolumab trials? We had some more infections in the Anifrolumab treated patients. And when I say infections, we're talking about upper respiratory tract infections, like common viral infections, UTIs, and then bronchitis. Was this unexpected? No. The Anifrolumab and like the other biologics, like the other new drugs, are supposed to suppress the immune system in lupus. So the more the suppression, the higher the chance that you will get an infection. Thankfully, most of the infections were like very mild infections. They didn't need anything specific. Right? The patients did not discontinue the medications. They were treated and everything went well. What was the one infection that stood out in patients with Anifrolumab? Herpes zoster, singles. It was like 4 times more frequent in patients who were treated with Anifrolumab, if you see here. So we're talking about 5, 6, 7% of patients with Anifrolumab who will get a herpes zoster. This virus is the chickenpox virus, right? We all have this. Like in Greece, it's more than 99% of the population had chickenpox at some time. And then whenever the immune system is low, whenever it's suppressed from the drugs, from the disease, because you don't feel well, right? We have seen this even with psychological factors, you will get that herpes zoster. In the majority of cases, about 60-65%, no significant issue apart from the week or 2 weeks that you will have this rash and pain. Right, in the rest, they may have some issues with nerve damage and persistent pain after the clearance of the rash. That herpetic neuralgia, we call it. So that stood out, and we need to be aware of this. I guess we can vaccinate our patients even before the initiation of treatment, if needed, and then we'll protect them from this adverse event. So to wrap it up, we had patients with moderate to severe lupus. Again, no kidney disease, no central nervous system disease. They did very well. They did significantly better when it comes to outcomes compared to patients who were treated without all the other medicines, without the new medication. The new medication caused some more infections expected. What stood out was herpes zoster. Now, a few practical things for Anifrolumab. Anifrolumab is an intravenous drug. It's administered every 4 weeks at this dose of 300 milligrams per day. The duration of infusion is 30 minutes. So a patient who is taking Anifrolumab should go to an infusion clinic every 4 weeks, every month, get the infusion for 30 minutes, and then she can go home and relax until the next infusion. Right. In my opinion, a very, very significant drug. And I told you, although we saw some significant difference, statistically significant difference anyway, this is for the papers and for the publications and for the regulatory authorities to decide. What I'm saying is a significant reduction in the dose of steroids and less damage. And when it comes to this, if I was like the decision maker here and you were telling me, look, you're asking me to approve a steroid sparing agent for $60,000 or $70,000 a year, I would tell you that this drug, like the other drugs, and the Benalista, the other drug we have in lupus, the other biologics, will save money indirectly, will save osteoporotic fractures, will save vascular necrosis and surgeries, early surgeries for hip replacements and knee replacements, will save flares and hopefully renal flares that may lead to end-stage renal disease and dialysis, will save major cardiovascular events because our patients will take less steroids. So you will get your money out of all this. Right, when this will happen, will this happen like in the next 2 months or in the next 3 months? No. We have to be patient for this, and we have to assess the data in like a period of time, in my opinion, in the first 5 years. Right? Can we be patient for the next 5 years as decision makers, as the government? I don't know. We're trying to convince them. And I'll get back to this in a few minutes. Now, a few things about the other drug that was approved by the FDA for lupus nephritis. The name is Voclosporin. Aurora is the name of the trial. Right, not much about pathophysiology or things like this. Anyway, kidney disease in lupus. About 40–50% of patients with lupus will have kidney involvement. So it's almost 1 of 2. Right, what is the trouble with kidney disease? If you have kidney disease, you have, in the next 10 years, you have a 17, they say, according to a meta-analysis, 17% chance of getting to end-stage renal disease. That means dialysis. If you go to dialysis, you have about 10 times more chance to die from the disease. Because kidney failure means that you will have elevated blood pressure, hypertension. All the metabolic profile will go wrong. You may have acute complications during the dialysis. You may have other trouble. It's a mess. Dialysis is not an easy thing. And I'm telling you, I had extensive training for 2 years in dialysis unit. I was taking care of people who were having this dialysis. And we were seeing all the complications in these patients. It was really tough. And you have this on a daily basis, on a weekly basis. It's not a matter of something will happen once in a year. No, it will happen again and again and again, on a daily or weekly basis. Anyway, they checked patients with lupus nephritis class 3, 4, or 5. We have, based on the biopsy, we'll take a little piece of the kidney, we see it under the microscope, we examine it, and we say, look, you have lupus nephritis class 3, or class 4, or class 5, or whatever. 3 and 4 and 5 are the most aggressive of the types of lupus nephritis. And they asked for a significant amount of protein in the urine. People with lupus nephritis lack protein in the urine, and the higher the protein, the higher the chances that they will not go well. What happened? They didn't include any patients with advanced kidney disease, so they caught them early. Right, and patients who were not caught early were not included in this study. We have not done any significant research actually for patients who had an advanced disease to begin with. We were the only group in Toronto who checked these people about 3 years ago, and I published a study. About 60% of them will not go to dialysis if you treat them well. About 40%, they will go on to dialysis. Now, if you compare this to the 17% I told you about, it's more than double the chance to go on to dialysis. What is this new drug? It's a pill, actually, and not an infusion, right? Plenty of pills, to be honest, because you have to take 3 in the morning and 3 at night. But anyway, it's oral. You don't have to go to an infusion clinic or anything. These patients were treated with steroids and mycophenolate, the Cellcept or the Myfortic, as we know it better. And what they asked, what was the primary endpoint? For patients to have complete renal response. Complete renal response means no protein in the urine. Anyway, not more than half a gram a day. You will have a normal or near normal kidney function at the end of the study. You will not use any rescue therapy. If a patient goes bad during a clinical trial, I will not ask the sponsor or anything, right? I will give him or her whatever I think to rescue the kidneys in this particular case. And they demanded the low dose of prednisone from weeks 44 to 52, and that was the first for the for lupus nephritis trials. So they did all this. They randomized. They started with 728 patients. They ended up with 179 with the drug, 178 with the placebo. Again, placebo, all the other drugs, but not that new drug. So this is not a drug that you take and replace all the others. This is an add-on. No significant differences when it comes to the baseline, how they started. This is the meaning of randomized controlled trials. So you have like a certain population, and then you randomize them by different methods. Now we have computerized methods. Back in the day, we were saying first patient gets the drug, second patient gets the placebo, third patient gets the drug, fourth patient gets the placebo, and so on. What we are trying to do this, we are trying for the groups to be balanced when they start. So they will have like a similar age, similar disease severity, similar kinds of lupus nephritis, similar intensity, the severity of the proteinuria, as similar as it gets. So we won't have any other factors that could explain any differences we may find in the analysis. Right, and what happened when they analyzed the data? They saw that patients who were treated with Voclosporin had a significantly more good response compared to the patients who did not take this drug. The primary endpoint was analyzed at week 52 at the end of the trial, again 1 year. Right, 41% of patients with the Voclosporin did very well, and that's it to this endpoint versus 23% of the patients with placebo, and that was like significant. And based on this, the drug was approved by the FDA. This, the right panel, is the partial response. By partial response, we mean a 50% improvement and not complete improvement like the other one. Still a good outcome, okay. Nevertheless, if we're going for complete response, it's always better to have a complete response than a partial response. In lupus nephritis, it may be a matter of time, like few patients will achieve a complete remission within the first year since treatment initiation. Some of them will achieve remission in year 2, in year 3, in year 4, and all these things. So even if you have an indication that something is going towards the right direction, for example, this 70% of patients who had the partial response, it's an indication that, okay, we're doing well, keep doing what you're doing. Now, if we go to proteinuria alone and not all the other issues like kidney function based on the creatinine, this is like a blood test, or less steroids from week 44 to 52, the probability that you will have a normal proteinuria by the end of the study, day 365, was almost like 65 to 70%. Why is this important? This is important because we will not see the creatinine going up. That means that the kidney function is going down until after years of leaking protein in the urine. So this is the best surrogate we have to assess what's happening with the kidneys. If you don't have any protein in the urine, you will do well. If you do have protein in the urine, things might not go well. And this was significantly in favor of the new drug, that Voclosporin. When it comes to adverse events, no significant issues this time around. You will see some horrible numbers. For example, here, if you check adverse event, 91% of the patients in the Voclosporin group and 89% of the patients in the placebo group. So, oh my God, like 9 out of 10 will get an adverse event. What is an adverse event for a clinical trial? Whatever happens, it will be registered, documented as an adverse event. For example, if you slip on ice because it's February in Hamilton and there's snow everywhere, this is an adverse event, right? If you have like a fracture because of this, this is a significant adverse event because you will go to the hospital. Right? Is it related to the start treatment? Most likely not. Who's the adjudicator of this? Who will decide if this is related to the drug or not? Usually the treating physician. So if I have you in a clinical trial, I will say that, look, this is related or not related. Okay, and if you go to this, you will see that treatment-related serious adverse events were 4% and 4%, so no significant issues. When it comes to infections and infestations, 65% in the Voclosporin group, 57% in the placebo group, so slightly more in the Voclosporin. Again, it's an immunosuppressive as well. We expect some more infections. Thankfully, again, no serious infections in the vast majority of the cases, the patients did well. So we discussed about this, and we had a discussion, and I would like the president of Lupus Ontario, Linda Kiel, to assist me in this. A few days ago, we submitted a document to Health Canada in order to support the application of Anifrolumab for public access. By public access, I mean the drug is available in Canada if you can pay for it, and the cost is significant, very significant. What we're asking from this is that some more patients will have access to this drug. And why I'm asking about this? I'm asking about this because not all patients have any private insurance in Canada. And some of our patients may need it more than others. What I mean by this, if I have a patient who's doing very, very well on Plaquenil alone, there's no reason for this patient to go on to a new drug that may give him trouble without any expected benefit. For a patient, however, who has like plenty of flares and is not well controlled and is taking 20 or 30 or 40 milligrams of prednisone for a long time, and it's more than certain that this patient will develop damage in the long term, in the next couple of years. And this patient, in most cases, is a young woman of 30, 35, 40 years of age. Why this patient should not have access to this drug? And why this patient should not have access to the drug, not forever. I'm not asking forever. In the document I submitted, and I had, and like I thank them for this, other members of Tselios group, the Canadian Network for Improved Outcomes in Lupus, it was a Canada-wide effort. I proposed certain lupus patient groups actually to have access to that. And I asked them to have access at least for 12 months. Right, so if in 12 months, allow me to give them the drug, and if in 12 months we haven't seen anything significant, okay, I will stop it and I will not ask for more. But if the patient does well, I would like to continue with this drug for as long as it provides benefit to the patient. Right. A similar letter of support was submitted from Lupus Ontario, from the patient's perspective. Because now we ask, and thank God, we ask our patients for their perspective and for their opinion in this. Right. What I'm thinking and what I was discussing with Linda and the other members of the board for the approval of the drug. If I was like a policy maker, a decision maker, I would ask for the numbers. Why? Because like I have a big chunk of money, and I have to give this to people with diabetes, to people with cancer, to people with mental health problems, and this should be respected, right? So I would ask you, okay, Dr. Tselios, what is the impact of lupus? What are you talking about? You're telling me about like 10 patients and then 100 patients. So what? Because we have, when it comes to lupus, we don't have that 1% of rheumatoid arthritis. We have that 1 in 1,000, right? Maybe 1.5 in 1,000. So we are few. My issue is, and my thought is that despite this fact, the impact of lupus on society is disproportionate, because we're talking about young women who will get out of the workforce, who will go on disability. Like 40% of patients with lupus will go on disability in the first 5 years of disease. Right, about 10% of lupus patients will have an osteonecrosis, and 5%, half of them, will have a joint replacement before the age of 50. Joint replacements in the general population happen at an average of 70 to 72 years. Right. Patients with lupus about 5-6% of them will go to dialysis in the next 10 years. Right? What is happening with these patients, and how you're going to account for these patients? So what I'm thinking is how we can help this, and how we can create a map of lupus in Ontario and hopefully Canada-wide. What I mean by a map, I'm not asking that you will give me your address or name or anything. No, we're asking about the identified data only. But if I'm able to say to the government that, look, in Ontario, I have Lupus Ontario, the organization that represents like 2,500, 3,000 patients with lupus. And of them, that many are women, that many had trouble with the joints and they had like an operation for the joints, that many had a major cardiovascular event, a heart attack or a stroke, that many had kidney issues and dialysis, that many are taking like steroids now as we speak, and that many were visited the emergency department in like 12 months time, or whatever you think may be relevant. I'm trying to think like the minister now, to go to the other side and say, okay, why are you asking me to approve new drugs? Anyway, this is like up for discussion. I'm thinking to have like a more complete proposal to the board of Lupus Ontario, and I'm willing to work together for this if the patients are willing to help, right, on how we can assess this, how we can voice our concerns, and how we can improve access to healthcare services, healthcare products for the lupus community. So I will stop here. Take questions, whatever you want.
Okay. Thank you so much, Dr. Tselios. Yes, I'm sure there'll be many questions. We will open up the chat. You can write your question in the chat. Rapinta, another committee member, will be monitoring the chat and will be reading those questions to Dr. Tselios. Again, this information, I know it was a lot. You probably definitely need to go and review it. We will have the recording, and Dr. Tselios will give us the PDF copies as well, so you can go back and review it. Now, before we open up the Q&A, Dr. Tselios, you mentioned one thing, so I just want to follow up on that. You mentioned about having access, to get help as far as bringing this to the government. So Linda is on the call, so I don't know if she would like to chip in and say anything as far as Linda is our president of Lupus Ontario. For those who are new, I know there are a few new people on this call today because in the last day, I think I got 3 or 4 new diagnoses that came through the support email, and I did invite them to join this webinar, and I do see a few of them have joined. So Linda, maybe you could just follow up quickly what Dr. Tselios mentioned about getting that support, and is this something that from our membership that we will need to maybe do a survey of sort, so find out who might be interested in, and then Dr. Tselios can give us the information that he's looking for. We could, we do have our monthly newsletter that goes out to all our members who we do have their emails, which probably everyone in this call should be on that list. So any comments at this time, Linda? Or do you want to just go into the Q&A and then Dr. Tselios could maybe do something and we could get it out to our members through a newsletter or maybe he'll come back again and we can do a follow-up.
I'd just like to say a couple of things. First of all, good evening, everybody. I hope you enjoyed the webinar. I know I did, and I'm looking forward to the question period. So we recently completed a focus group with 10 of our members in order to prepare the information to go into this document that Dr. Tselios spoke about to support the approval of this drug, the Anifrolumab. And we learned some interesting things out of that. But, you know, basically our sample was too small and we didn't cover all the areas that this new survey would cover. I think one of the keys to success is getting enough, you know, a big enough sample of people, and also to get good coverage across the province. I think everyone knows that in certain areas of the province, in fact, geographically, probably if you look at the area of this province, the GTA is fairly well served, but once you get outside of the GTA, access to care isn't so great. And that, I think, is another thing that we need to think about. And I know the ORA, Ontario Rheumatology Association, is also working on that. But this survey would be specific to, as was mentioned, you know, the health challenges that people have, the fact they have lupus and then they have other comorbidities, to try and get a picture of where there are shortages across the province. And just that data to say, you know, that certain percent of people have osteoporosis, a certain percentage have heart disease, kidney disease, on and on, will definitely be better data for the government to decide to approve this drug, to sort of lessen the burden on the patients and the healthcare system across the province. So this is going to take a bit of planning to scope out. Don't expect anything in your mailbox in the next week or so. But I think we really need to design this survey very well and really think about how to collect enough data. But one of the keys to that would be to have as many of our members as possible complete the survey. And as was mentioned, we're not going to use your name. We may ask for the first, in order to figure out the geography, we would need the first 3 characters of your postal code. That would be it. And I know I saw something flash up in the chat about don't forget the men. When we ran our little focus group, we did have a man on the focus group. You know, we got the 10% coverage, and we did have people from across the province, which was great. I want to thank those folks. I know some of them are on this call tonight for participating, but I guess the message is stand by. We will be having further discussions on this to try and come up with a really well-designed survey that would add value to this approval process, because I think it's critical that there's as many effective medications as possible out there for lupus patients. So I think that's it for me, and I'll turn it back to Rupinder to manage the questions.
Thank you, Linda. And thank you, Dr. Tselios, for a great presentation. So I will start with the questions. Our first question is from Eleni. Eleni is asking, she says, I know Anifrolumab is a new drug, and thank you for presenting it to us tonight. In your experience, what are some of the side effects? Does it...
I discussed about the side effects. It does not interact with other medications like the Plaquenil, steroids, and immunosuppressives. What stood out was the herpes zoster, the singles. Right, these patients, I don't think they're going to vaccinate in the clinical trials. I mean, they were not vaccinated against the singles, but I would recommend this to my patients with who will start in the next little while with the Anifrolumab. Shingrix, the vaccine for shingles is safe for lupus patients, no issues, no nothing. The old vaccine, that Zostavax, we had some issues, right? And this is flares. It was not so effective. Shingrix is more than 95% effective, if I'm not mistaken, and is absolutely safe for lupus patients, right? So if you have like a history of shingles, I would recommend that you will get the vaccine before starting anything like this. Okay,
that's good to know. Okay, so that was the second question as well, was related to Shingrix. And then Paulette also, oh, it's the same question, has already been answered. And Christina's can Dr. Tselios confirm which vaccine we can have? So I think that's the same vaccination against shingles. So again, Shingrix.
We're talking about Shingrix, right? This is safe for lupus patients, not the previous one.
Right. And would Voclosporin be appropriate for someone who's being well managed, but still on prednisone and MMF?
That depends on what you mean by well managed. Like if you have active nephritis, by active nephritis, we mean protein in the urine above 0.5 grams per day, about half a gram, right? This is not the ideal response. If you have like less than 0.5 and you can get rid of the prednisone safely, no place for the Voclosporin. If not, yes.
Okay. Okay, and we have just a compliment for Dr. Tselios. You are an absolutely fabulous doctor from Christine. We'll say those two, not just the questions. You may have mentioned this, but will this drug benefit all lupus patients or those with less severe symptoms?
You mean for the Anifrolumab?
Diana, could you clarify whether you mean which drug you mean?
Yes, we have mentioned it, but this will benefit all lupus patients or those with less severe symptoms. I guess for the Anifrolumab we're talking, and not for the other, for lupus nephritis. What I asked from Health Canada, and I'm telling you this because it has now been submitted. I don't mind, and I prepared this document like by myself. One, patients who have active disease, right, and will not respond to the standard of care. By standard of care, we ask about Plaquenil, we ask about steroids, and we ask about immunosuppressives. So if I give you these three and you will not respond, or you're still taking prednisone after like a significant amount of time, let's say I'll give you 6 months, that's what I wrote, and you will not get into remission, I would like to have the option of Anifrolumab. The second category is the patients who are steroid dependent. We have a few patients who cannot reduce the prednisone below 7.5. They're taking 15, they're taking 20, and whenever they try to go below this number, they flare. So for these patients, I asked I would like to have the option. And for patients who have frequent flares, like 2 or 3 flares a year, despite treatment, regardless of the organ that is affected, regardless if it's the kidneys, if it's anything else, I don't mind. Like for a patient like this, I would like to have options. Why? Because more flares, there's more damage, more steroids. These patients will go on to disability and will have like irreversible trouble in the next 1 or 2 years. Right, and I need to act now.
Okay, thank you. From Chaudhry, hi, Dr. Tselios. I believe you work with my sister, Dr. Semalulu. I'm a man. Yes, it's Chaudhry.
Who is this?
Chaudhry Semalulu.
Chaudhry?
Yeah. So he is a man living with lupus nephritis for 15 years.
I can't find him. I know, Chaudhry, I know your story.
So he started Benalista yesterday after Rituxan, which he took for 6 months, or he took 6 months ago. He's on Imuran and is asking, can you take Benalista with Voclosporin?
Benalista with Voclosporin. That's a great question. We don't have any data. I will check and let you know. I'm not aware of anything in the trials like Benalista and Voclosporin. Benalista had shown some wonderful results in patients with lupus nephritis as well this past year, and I think that it will help in the long term very, very well. Now, if you need Voclosporin on top of this, we have to be very careful here because you have already have like a significant amount of immunosuppression, right? And they would do this only if there was no response to Benalista. I would give it some time on Benalista, right? Benalista is not working like overnight. These drugs like medicines that need time, and they will do wonderful if you give them time.
Okay. So
And
he's,
whatever happens, whatever comes up, I'm talking to your sister like every other day. Right? So they will transfer this to you.
okay. So if you can see also in the chat that he's followed up to say also, how do you take the COVID vaccine with Benalista 4th dose, the
Yeah.
booster? So he should just go ahead and take it.
This is in long-term remission for extrarenal flares. And what is Benalista efficacy on lupus nephritis compared to Vocalosporin? Okay, we don't have like a direct comparison between Benalista and Voclosporin, right? Voclosporin is only tested in lupus nephritis. Benalista is for everything in lupus. So I would go for Benalista for the moment. If you're taking infusions of Benalista, I wouldn't have any trouble having the shot, the COVID-19 shot, in between the infusions. Right. You patients with lupus have a like a lesser response when it comes to vaccination, not only to COVID, but then any vaccination. That's why we were asking like for boosters and 4th doses and all these things. For the 2 first vaccines, we had a response rate of 60-65%. By response, I mean like people who had antibodies against the COVID vaccine after the first two doses. Right, so only 2 out of 3. That's why we were asking for the 3rd dose and then the 4th dose.
Okay, so you are recommending that people with lupus get the 4th booster dose?
People with lupus, particularly those with the heavy guns, like severe immunosuppression, with biologics, with high doses of steroids, with mycophenolate, I would recommend this, yes.
Okay, so that's that question. And then another question, how effective is Symbolta for pain?
Symbolta for pain. Symbolta is not a painkiller. It's primarily an antidepressant, right? What we saw in patients with depression who were treated with Symbolta is that the pain in a significant proportion of them was better after a few months on Symbolta. It's theoretically modulating your perception of pain. So you will have to have a stronger stimuli to feel pain. And my patient with fibromyalgia is providing some benefit in about half of them, not more than half of them. Right, and of course for fibromyalgia, we go to significantly higher doses than those of depression. We go up to 120 milligrams per day, for example. Instead of 30 or 60 that is commonly used in depression. Right, it's a different issue. Fibromyalgia is a complicated, under-recognized. We don't know much. I'm for my patients with fibromyalgia, I'm trying to realize what happened and they got there. Right, it's multifactorial. Sometimes it's like poor sleep. Sometimes it's like a psychological stressor that happened early in life. Sometimes it's depression. Sometimes it's like an accident they had like 10 years ago, and since then they started having this trouble. Sometimes it's an issue of the disease itself, right? Like an active lupus or a frequently flaring lupus to cause that chronic pain. It's not only like one way or the other, like multiple ways can lead to fibromyalgia. It's very tough to treat. And I know Symbolta well, like I have been prescribing this for many years now. About 50% of patients will respond well. We'll have like something meaningful.
Okay, thank you. Is protein liquid good for kidney patients?
Protein liquid, you mean the protein preparations that like the Ensure and things like this?
Sumita, is that what you mean? Like an Ensure?
If this is what is meant by the question, the nephrologists are not recommending protein more than 40 grams a day in patients with advanced kidney disease. So if you're on dialysis or close to dialysis, it's not great to have like an increased amount of protein. They reduce this, they restrict this to 40 grams a day. 40 grams is like, how big is this? Like half an iPhone.
Okay.
Of meat or dairy or something like this.
So that is what Sumita was asking.
Theoretically, it accelerates the rate of kidney damage. Right, too much protein.
Okay. So is there any information for the effectiveness of Anifrolumab with SLE patients with uveitis and scleritis?
No, actually, it's so rare that we didn't have any patients with that kind of trouble. But we have, when it comes to the eye in lupus, we have like patients with eye trouble, really very few. I can count them like in my career, how many I had. I can count them like in one hand. Really complicated patients, really takes a lot to fix them. And most of them, what we're trying to do with patients with eye disease is to manage this, like it's a sight-threatening disease. These people, if left untreated, they will get they will end up blind, right? And it's like a huge comorbidity. Like you can't accept this. It's not like something will happen and we'll replace a joint. No, you cannot replace the eye. Like this is like an emergency, right? And we usually are fearless when it comes to this. With regards to prednisone, we give tons of prednisone. Why? To save the eye. And then we're trying to find other solutions actually to decrease the needs in prednisone. We're talking about huge doses. We're talking about combinations of drugs, multiple drugs. We're talking about topical treatment with intraocular injections in the eyes. Like we have to have a good collaboration with the ophthalmologist and expert ophthalmologist. It's not an easy thing. And because of its rarity, it's not represented in clinical trials, unfortunately.
Okay. So the question related to the protein drinks, there's a follow-up about any recommendations for diet for patients with kidney disease.
They have actually several recommendations. You can even, like, if you Google it, advanced chronic kidney disease or chronic kidney disease and diet, you will find a lot of diets. What I'm asking my patients in general is, one, to cut down on salt. By this, salt has been proven to be directly related to hypertension, elevated blood pressure, right? And blood pressure is what kills the kidneys in the long term. Even if I treat your lupus nephritis, if hypertension remains, it will kill the kidneys slowly. Right, then sugar. Why? Because most of these patients are taking like even low dose of steroids as well. And it doesn't help. Steroid by itself will produce some insulin resistance. And by insulin resistance, you're in a pre-diabetic state. How many patients will develop diabetes? We're talking about 3 or 4%, not many. About another 20% will have like insulin resistance. And by this, they will have multiple metabolic abnormalities that will promote kidney damage. So less salt, less sugar, and I'm all for less processed foods, less white flour. Right. when I'm asked for anti-inflammatory diets and things like this, the typical anti-inflammatory diet is impossible to sustain, impossible to do, like practically impossible. If you're interested to see this, there is a site from Harvard. They started doing this in patients with ulcerative colitis and Crohn's colitis. It's called IBD-8, Inflammatory Bowel Disease Anti-Inflammatory Diet, IBD-8. And if you read this, you will be depressed, right? These people are not eating sugar, nothing from sugar, nothing from salt, nothing from bread, nothing from this, nothing from that, some seeds here, some seeds there, plenty of vegetables. And you're supposed to have this for like forever. They started, 40 people started this in about 2006, 2007. None is doing this now, as we speak. It's very hard. It's impossible.
We do have some nutrition related webinars on the website under the education section. If people want to go there, we have about 3 different ones there you can get some recommendations from.
That's fantastic.
And then Tacrolimus versus Voclosporin. Why would Health Canada not go with the cheaper option? My nephrologist said Tacrolimus reduces protein but damages the kidney later, but Voclosporin is safer, Canadian made, and you don't need the lab work Voclosporin requires.
Why go for tacrolimus? We have some data for tacrolimus actually, and that was given on top of the other medicines like the MMF, the mycophenolate-amine, and the prednisone. And this patient did well. And we have tacrolimus in Canada, and we're actually using this in patients with lupus nephritis, and they, most of them will do very well. Right? What is happening with the Voclosporin? We have another option on the table. Right? Can we live without Voclosporin? We'll live one way or the other. Right? In Voclosporin, to give you an idea, if I'm not mistaken, it costs about $90,000 to $95,000 a year. Right? If we can have this for refractory patients who will not respond to tacrolimus, yes, I would love to have this option. But when it comes to lupus nephritis, if you want me to give you numbers from Toronto, because I was studying this for 6 years, in the first year, we'll get 50% of our patients in complete remission. This will go to 72, 73% in 5 years, complete remission. We have 6% of patients ending up in dialysis compared to 10% worldwide. And we have how many? We have about 5% deaths in patients with lupus nephritis. Like worldwide, it goes up to 8 or 9%. So we are doing well, right, with the existing drugs, yes. But I would love to have something from for the 1/4 of our patients who will not get into remission like quickly, relatively quickly. With tacrolimus, I can have some more. With Benalista, I hope that this 75% in the first 5 years will jump to 90%. Right. So I'm looking for options for the refractory patients. Like the majority of our patients will do very well, yes. But what's happening with the patients who come late during the disease course? I had patients who came to me on the verge of dialysis, right, because they were not treated properly. This is the inefficacy of drugs, refractory disease, lack of access to healthcare, lack of access to a specialist. Something is happening. Like I have found like many reasons for this, but and I think we have to see this in like a broader perspective.
Okay, thank you. So the next question, my doctors took me off of medication related to lupus, hydroxychloroquine or chloroquine, for example. Should I be on something?
That depends on the condition, actually, and I would suggest to trust your doctor.
Yeah, you might need more information.
For him to discontinue the Plaquenil or the chloroquine or whatever you were taking, they probably saw something that was indicating that something is going on with regards to toxicity, something from the eye, something from something else. We don't stop the Plaquenil for nothing.
Okay, thank you. My sister has, I always say this wrong,
Surgeons.
surgeons,
Yes.
and is having, yes, she is having increasing problems with her eyes, especially since her cataract surgery. She's been told her corneas are damaged because of the surgeons. Any recommendations?
Recommendations, you will discuss it with the ophthalmologist. When it comes to Sjogren's, actually, we only have topical treatments. Very, very effective, something called Restasis. This is Voclosporin eye drops. It's supposed to suppress the inflammation in the lacrimal glands. If this is not effective, we are asking for something called Zidra, other eye drops that's rather effective. And in some patients who did not respond well to the combination of eye drops, I asked the ophthalmologist to put some plugs in the ducts here. So your tears, whatever tears you're producing, they will not go straight to the nose, but they will remain under the eyelid, and it will lubricate the eye bulb. Sometimes I've seen very refractory patients, we are making eye drops from their blood. These are better from their own blood, right? Not from anybody else's, so you'll have a reaction or anything. They take your blood, they will process this, and they will get like albumin from yourself in a bottle. This stays for longer on the surface of the eye. It has the ability to heal any ulcers, any micro injuries in the cornea, and it will help you.
Wow.
We are doing this in McMaster. I think they're doing this in Toronto. I'm sure they're doing this as well.
Okay, very interesting.
1 second, Rupinder. We also had a webinar. We had a panel discussion, and we did have someone from the society who was there. So again, visit our lupusontario.org/education. Those will be posted there as well. Okay, Rupinder, thank you.
Okay, and can you take Imuran with Voclosporin?
You can take Imuran, yes. It didn't have any trouble with the mycophenolate, and they wouldn't expect this to have any trouble with the Imuran. Now, the Voclosporin, the truth of the matter is that Voclosporin was tested as the remission induction agent. By remission induction, I mean the first phase of the disease where you're taking active treatment. And then there is the maintenance phase for many, many years where you were taking the immunosuppressives, and MMF is theoretically better when it comes to this. Now, for the patient to take azathioprine, I gathered that they were not tolerant to MMF, most likely. So we can go with azathioprine as well.
Okay. And you mentioned, when you mentioned that below 5 to 7.5 milligram prednisone long-term does not usually lead to problems, is that in general, or is that in combination with other drugs you presented?
No. Prednisone alone actually can cause damage with a dose as low as 5 milligrams per day. When it comes to 5, actually, the only thing that we saw in patients who were taking 5 for many, many years is osteoporosis and osteoporotic fractures. We didn't see any increased incidence of steroid-induced diabetes, for example, right? Or any osteonecrosis. Osteonecrosis will happen like really, really early after the initiation of prednisone. So what we saw, and we published the paper, is that if you're taking 5 milligrams per day of prednisone, you will get some damage, particularly osteoporosis. While if you can take the prednisone down slowly, one by one, you will be able to cut it, to get rid of this without any significant issues, and of course with less damage. How many patients were able to do this? 80 to 85%. To reduce from 5 to 4, 3, 2, 1, and then 0.
Okay, thank you.
Usually, like if I have drugs like the Benalista, like the Anifrolumab, to allow me to go to 0 prednisone, I expect less damage in the long term, but damage will not be measured in 1 year. I don't expect that this will become apparent in clinical trials, right? From the Benalista, yes, because we now have data for 10 years, right? And it has shown significantly less damage. So this is a major goal in lupus, and we have like to voice it somehow that we don't want that amount of prednisone for our patients in the long term.
Okay. I don't think we have any more questions. Kathy just
I
thanked
think
you
there was
for-
one. I think there was one last one. Did you get the one about the prednisone? The 5 to. Okay, so when you
Yes,
mentioned.
yes, we talked about the 5 to 7.5
Okay, so we
milligrams.
got
of
that.
insulin.
Okay, yeah. So I think there was just another just a comment thanking Dr. Tselios because regarding the mention of the eyes, the process for the eyes. Okay, so thank you everyone for staying on. I know we went a little bit over time, but I know this was very important to most of you that were on this call, and I wanted to make sure we did get all the questions in. So thank you, Dr. Tselios, for staying on and doing that. Again, I'd like to thank Dr. Tselios for joining us again for this wonderful webinar. Again, it will be posted in the next few days. I'd like to thank our President, Linda Keel, Rupinda, for monitoring this webinar tonight, as well as the office staff, Martina and Hajraj, who has been here doing the recording and helping out with the chat as well. So thank you so much, everyone, for coming. We look forward. Please keep an eye out. Like Linda said, not right away, but perhaps in the next little while. And we would appreciate any assistance you can give in helping to find a solution and improve, improve the life of those living with lupus, as far as getting these drugs in their treatment plan, as opposed to it being so expensive that it's out of reach. I mean, what's the sense of having a drug that's going to help us if we can't afford it, right? I know that is the problem with Benalista. It's been a huge issue. Most drugs company don't cover it. I'm not sure if these ones are going to be any different. Dr. Tselios, any feedback on that as far as that goes?
No, it's early actually. I'm expecting an email from them by next week.
Okay. Okay.
We'll see. Anyway, we made our effort, right? And I really believe that if we are able to do this survey and have some data from Lupus Ontario, I think, Linda, this will be a first, right? There's nothing similar from Lupus Canada, if I'm not mistaken.
I don't think so. I know they did a survey a little while ago, but it certainly didn't do anything by location. I think,
Right.
no, I think this, and obviously, like, Ontario has probably well over half the lupus patients in Canada.
Okay.
So I think, our focus would be to lobby the Ontario government to approve this. Anything to do with cost is going to be a provincial matter. So I'm not aware of any other data collection like this. We'll ask around to see, but I think this would be something that's new and important.
Right. Okay, well, we'll try to work on this.
Yeah.
And
Okay, well, thank you.
Really request your support, right, from the Lupus Ontario members and the lupus community on how to improve this and how we'll voice our concerns and protect our interests.
Okay, so again, thank you, everyone. Just a quick note for those of you who are still on the call. Our annual AGM will be March 26th with special guest, Dr. Murray Uritz, and we'll be doing a special tribute to him. As many of you know, he will be retiring or partially has already retired. And please note as well, we will be having a silent auction for the normally we would have the lupus dinner dance, but again, because of COVID, we have moved that online to a silent auction. So please just visit lupusontario.org for all the upcoming events, and please support those causes. We appreciate your support tonight. Again, thank you very, very much, Dr. Tselios. Again, as always, you bring everything to the forefront for our members, and Lupus Ontario do appreciate you taking the time to volunteer with us. Thank you, everyone, for attending tonight. Have a good night.
Thank you. Thank you. Good night.
Good night.